Well, thank you, Dr. Cosignani. First of all, I wanted to thank Professor Cittadini, Dr. Gianaroli for the kind invitation. And also I would like to share with you, it's a privilege to speak after André van Stertingen. And I learned everything I know about IVF at the Brussels Free University under the mentorship of André. I should recognize this. And I'm going to share with you what has been my experience in assisted fertilization since I've been overseas, really, in New York. So if we look at incidence or the indication of infertility, if we exclude about 30% between combined and unexplained form, you see that the indication is equally distributed between the male and the female partner. Now, when we approach about the treatment of the male, we look at developmental history, medical history, surgical history, then we thoroughly examine the male, and then we do a semen analysis. And the semen analysis, if it's normal, then we focus on the female partner. If it is not, then we look at other characteristics such as the endocrine profile, and then if this one needs to be addressed, together with the reproductive urologist, at least in the United States, then we address those. If not, then we try to tweak the insemination procedure in order to make the best out of this impaired semen sample. The semen analysis have been revised in 2010 by the WHO. We look at different just general characteristics, abstinence, volume, viscosity, concentration, morphology. The motility is present, fine. If not, we look at the viability or at the presence of other cell. Still has a lot of limitations, so we look at other characteristics. One is we have to consider when we examine the male, there is a higher incidence of chromosomal abnormality, like in this study here from Japan on 1,500 men, when actually there is a larger component of peripheral autosomal abnormality and gonosomal abnormality, particularly between Klinefelter complete and mosaic forms. Also, if we look in detail, there are also micro deletion of the Y chromosomes. And this, if you see the tip of the arrow, indicate this STS that are missing in this patient, and has an inverse relationship with the concentration of the sperm. Indeed, in the Azoospermic Men, between 8 and 10%. Fortunately, in these men, if we retrieve spermatozoa, we actually get good fertilization on the 40 to 50%, and this in clinical pregnancy rate, about 36%. Throughout this paper, this presentation, when I speak about clinical pregnancies, the presence is defined as the presence of at least one fetal heartbeat. Then if you go even further and look at the characteristic, or the chromosomal characteristic of the actual male gamete, this is a study we did in 2002, where we actually saw that in men referred to our clinic, the incidence of chromosomal abnormality in their gamete was higher than the donor, was supposed to be 0.4, 0.5%. Similar, the incidence of chromosomal abnormality in the epididymal sample, when the testicular went all the way up to 11%. And this was quite concerning. And this could address the question on the audience when the sperm is compromised, what's the incidence of chromosomal abnormality are. But we revisited that a little later in the presentation. Then with the morphology, you can see this so-called decapitated spermatozoa. The concern is not only on the genome, but also on another organelle, which is the centrosome. That's something that we came forward in 1994, the first idea of the paternal inheritance of the human centrosome. And you can see with these anticentric antibodies, you can assess for presence and estimate the function of this organelle. The organelle is here, the proximal is responsible of creating the first mitotic spindle. The distally, it creates the scaffold for the flagellum. It formed the first spermaster that will allow the juxtaposition of the parental pronuclei. And once it replicates, it formed the first mitotic spindle, which will ordain the correct segregation of chromosome between the two daughter cells. It's important to consider cases with globosospermia where there is an abnormal packing of the chromatin, there is a lower amount of protamine, and there is also an abnormal presence of the acrosome and the perinucleal theca, and so the activating factor. It is important, therefore, to assess for PLC zeta. Here's a merged image. I frame it for you here. And then you see in the equatorial segment, you can see the presence of this cytosolic activating factor, important for activating the oocyte. To perform ICSI, you need the sophisticated machinery, which is the micromanipulator on top of an inverted microscope that allows to reduce the motion of your hand into the micro tools that are dipped into the droplet where the oocyte and the spermatozoa are present. This is the classical picture of the ICSI injection. These are the data on 24 years performed at Cornell of assisted reproduction overall, and is about 50,000 cycles. The proportion of ICSI when I joined Jack Cohen and Zev Rosemax in 1993 was about 30%. Then in 1995, Lucinda Vick came on board, and she tried to revamp standard in vitro insemination, but albeit didn't succeed very well because it kept increasing the proportion. And in 2002 was 73%. Since 2012, I've been on 80%. And I was mentioning to Andre earlier that since the beginning of this year, we have been running at 90%. So 35,000 ICSI cycles done in these 24 years. You see the large majority, over 90%, with ejaculated spermatozoa. The rest were surgically retrieved spermatozoa. You see here of these 32,000 performed with ejaculated spermatozoa. You notice the maternal age 38 with a big standard deviation, with about 84% abnormal spermatozoa. At least one parameter was abnormal. Fortunately, of 260,000 spermatozoa injected, the large majority survived. And of these, 77 of those that survive fertilize normally. It's about 5 to 6% of abnormal fertilization between 1 p.m. and 3 p.m. So this gives you an idea in terms of fertilization and pregnancy rate with ejaculated, electroejaculated, retrograde ejaculate. And you can see that the fertilization rate is about 70 to 77%, and a clinical pregnancy rate between 40 and 48%. In the lower part of the slide is the same sources with cryopreserved spermatozoa. Comparable outcome. They're not always the spermatozoa are available. There are specimens that look like these. So we look at a case with severe oligozoospermia with less than 1 million. You see the motility 20% and morphology only 1%. Fertilization rate still 63%, 47% the clinical pregnancy rate. Even farther, even worse cases, and you see the so-called cryptozoospermic patient where you don't see spermatozoa at the initial examination in the macular chamber, and these were called in the past Azoospermic Men. After spinning up to 3,000 G, we can retrieve spermatozoa, 350,000 here is the average, you can see there, and about 56% fertilization, still with about an average 1 conceptus replace, 46% clinical pregnancy rate. Now, if we look at the more severe Mer factor, you know the different indication can affect the production of spermatozoa. But the most relevant is azoospermia, whether it is obstructive or non-obstructive, about 23%. Now, these are the cases with azoospermia, 3,000 performed. Look at the maternal age is 4 years younger than the previous set of patients, 60% with testicular spermatozoa, the remainder epididymal. Obstructive azoospermia, mostly congenital bilateral absence of the vas deferens. You need to screen the male for cystic fibrosis carrier status. And also, it's important, it occurs after a reconstructible vasectomy infection of trauma, and is performed by percutaneous epididymal aspiration, the open approach that is mastered at Cornell by Peter Schlegel. And when the epididymal approach is not feasible, then the percutaneous testicular aspiration. These are the results. Similar number of cycles between the congenital and the acquired. You see the concentration, 20 million, motility 11%, the best, morphology 1%, fertilization rate between 70 and 72%. Clinical pregnancy rate 40 versus 53. Then we look at the non-obstructive azoospermia, and these about 10% of those were done in patients with obstructive azoospermia without clear epididymis. And then of those with pure non-obstructive, about 60% of the case we retrieve spermatozoa. These likely in half of them have the histology hypospermatogenesis, so we retrieve some sperm. The other half is equally distributed between maturational arrest and germ cell aplasia, where no spermatozoa are identified. The standard approach, the testicular biopsy, or the microtase that again is performed at Cornell. And the whole idea, I mean, it was proposed at Cornell by Peter Schlegel. Now it's done all over the place. And you see that try to identify the dilated tubule where there are residual foci of spermatogenesis. These are the results with testicular sperm aspiration. The obstructive case do slightly better. You see about 65%, 66% fertilization versus 48, 49% with a non-obstructive. The clinical pregnancy rate also mathematically superior in the obstructive cases, but still clinically significant at 37, 36, 37% in the non-obstructive. Just to compare the fertilization rate between the ejaculated whether fresh or cryopreserved, you see over 75%, with the epididymal 70%, whether fresh or frozen. The testicular is much lower, independently of the status of the specimen. Then we compare also the clinical pregnancy rate. You see with the epididymal is 60% versus 40% with the testicular. It's better also the frozen epididymal compared to the frozen testicular. And with Inish's procedure, the fresh perform better than the cryopreserved. Now, this is just a curiosity comparison because they have different indications. This on the background of this Mason trichrome that I borrowed from David de Kresser. This is the result with the Klinefelter patient with 229 patients, 60% chances of retrieving sperm. The delivery rate is 36% with about 86 children born with a very well-balanced distribution among genders. So these are the results. This may address the question on the floor that the severely compromised spermatozoa, what effect they have on the children. And these are data from the Ages and Stages questionnaire that we published on PLOS ONE in 2014. And if you can see, the ejaculated X is comparable to the standard ejaculated, with standard IVF. But the testicular spermatozoa, strangely, they do better, and we couldn't understand. And this was actually significant between the two counterparts. And even if it's the conventional IVF, standard ejaculated ICSI had higher incidence of children at risk comparing to the white line there, that is the 10% acceptable for the standard US population, mostly due to the multiple gestation. So we try to revisit a little bit the chromosomal status of the testicular spermatozoa. So we did this with the 9 chromosome probe fish. We saw that the control donor sperm is less than 1%. The ejaculated at about 2 to 2.7%. The epididymal and the testicular still at 1%. That's a surprise because the early study were few men, few spermatozoa cells, few probes. So, but then the criticism is how reliable is fish to perform this assessment. So, and if you see here fish, this little dot, these are the only chromosome, you see the chromosome 1 to 21, then you can see the very few probe and very little aneuploid is assessed. But if you use NGS, more powerful tool, you see you can assess all the chromosomes. It can go all the way to 4% in terms of aneuploid for each specific chromosome. So we repeat the analysis in individual where we were able to retrieve ejaculated and testicular spermatozoa. And these are the results with fish, the control, the ejaculated and testicular, comparable. And so with the NGS, was somewhat higher in the ejaculated, but certainly the message of the slide here is that there is no higher incidence of aneuploid in the testes, and this may explain the outcome with the children. So then another question we had was how long we had to search to find this spermatozoa that we need to inject our oocyte. I wanted to know if there was a time that after which was unnecessary to continue the search because no pregnancy, but these are the results. So we consider control when we found spermatozoa within 30 minutes, and then we did for the ejaculated up to 4 hours and a half, and for the testicular up to 6 hours and a half, up to 8 embryologists and time searching. And so if you see here, you can see that on the number of spermatozoa, when we start to go over the 3 hours, only few spermatozoa are identified. It is the power of 3, you can see here, sorry. And then when we look at the motile, only 1 spermatozoa identified here at the end. So for a total of about 1,000 oocytes for the study group, and here for the 31,000 for the control. These are the spermatozoa utilized for the control, and these for the study group. We will look in a minute at the results. This is for the testicular. Also here, very few spermatozoa seen, even lower, less spermatozoa when we look at the motile. And this for about 3,000 oocytes versus 7,000 in the control. This is the control sperm and the study group spermatozoa. And this actually, the spermatozoa injected in the ejaculate of this patient with cryptospermia, visual azoospermia, and this is the testicular. You can see they're far from being optimal. Still, these spermatozoa give babies. So the genotype is not reflected into the phenotype, luckily for us. So when we look at the fertilization rate, in spite of the time, the fertilization keeps being quite consistent, although lower than the control. Also for the testicular, similar scenario. Then we look at the clinical pregnancy rate. It seems to decrease over 2 hours of search. But for the testicular, it remains steady. So was the implantation. So that means that as long as you can find one sperm, doesn't matter how long you have been searching, whether motile or immotile, still you have a chance of fertilization, so you have a chance of pregnancy. Then we also look at something interesting, was if we inject actually spermatozoa that are motile, so they're viable, versus those that are immotile. And you see that the fertilization rate is 75% with ejaculate, and the pregnancy rate is around 40%, so the delivery rate. Similar situation with the testicular, if we use motile. If we use immotile, the fertilization rate drops for both groups, for both sources, and the pregnancy rate and delivery rate halves. So overall result, these are all fresh cycle. I did not include the outcome of the cryopreserved cycle. So these are the results in terms of fertilization. The bubble chart, so the fertilization is in the middle of the bubble with standard IVF. You see the 40%, the clinical pregnancy rate, and the delivery rate 35%. When you look at ICSI, you have about 75% overall between testicular and ejaculated, and a similar clinical pregnancy rate and delivery rate. And that's for a total of over 17,500 children born with fresh cycle at Cornell, since I've been there. And of course, the criticism is that the denominator for ICSI is the number of M2 oocytes, while for IVF is the number of total oocytes. So if we correct for those, you see that the two techniques overlap perfectly. The difference is that some couple cannot be helped by standard in vitro insemination, while they only benefit from ICSI. So the bottleneck of all what we do is the female age, and you see according to the maternal age, 35 years of age, the delivery rate, it goes to 38%, 39%. But when the patient reached 39 years of age, it dropped to 29%. And when the patient gets older, after age 45, the delivery rate became anecdotal. So ICSI, as Andre mentioned, been important for the surfacing of other procedures in the field, which is the application or the utilization of testicular spermatozoa, epididymal spermatozoa, in the immediately following years, 93 and 94. Then in the cryopreserved counterpart to this source, also been very important for promoting oocyte cryopreservation in 1997. PGD has been proposed in Brussels with ICSI, and in vitro maturation as well. So the indication for ICSI, for male factor, everybody would agree, whether it is oligozoospermia, azoospermia, or epididymal utilization of congenital bilateral abscess of the vas, or testicular. Everybody would agree the most controversial is the non-male factor, and where we use it at Cornell for utilization of donor sperm, cryopreservation of oocyte, low egg yield, advanced maternal age sometime because the low egg yield, and being proposed for discordant couple, for HIV, and for PGD, as I mentioned. So ICSI is now performed according to the data of the International Council Monitor and Assisted Reproductive Technology in 2016. In most parts of the world, these are the cases where ICSI is done together with IVF. These are the countries where over 80% are ICSI, and these are the countries where almost completely ICSI is absolutely ICSI is performed. These are the number of children born for the 3 years 2008-2010. The 2 million cycle of ART, 67% are ICSI, and the same percentage for the 1,100,000 baby born in this time period. So this is a general situation. So what is important to know is the incidence of chromatin fragmentation can be assessed in different ways. And there is a correlation with the paternal age. Yes. And there is also a positive correlation with the day of abstinence. We've done this study with Mark Gosling, our reproductive urologist. When the patient have a higher incidence of DNA fragmentation in the ejaculated tear, then you go proximally, and the vas deferens is reduced almost at level of threshold. The epididymis is even lower, in the testis is much lower. So when we look at the data here, you see when you do standard ICSI with ejaculated spermatozoa, in this patient you get a 16% clinical pregnancy rate and 8% implantation. But if you use surgically treated spermatozoa, the clinical pregnancy rate rises to 38% and the implantation as well. But we think this is somewhat aggressive. So we knew from a paper we published in 2014 that there is an inverse relationship with the motility and DNA fragmentation. So we use this new device, a microfluidic device, where actually we select the spermatozoa. We let the spermatozoa select themselves, actually. Where you can see that when the semen parameter initial, the density gradient, the concentration goes down, very much down, but the motility got almost 100%, and even the morphology improved, albeit not significantly. When you look at the DNA fragmentation, whether normospermic or oligospermic, there is an improvement with the density gradient, but it goes around 2% with the microfluidic. When you look at this patient, they receive a standard ICSI cycle with ejaculated spermatozoa. You got 19 cycles, 2 pregnancy, both end up in pregnancy loss. When we use microfluidic, we got 5 ongoing pregnancy out of 7 cycles. So we try to look for the best spermatozoa to utilize for ICSI. As you know, IMSI has been proposed. We did a study in the past with Laura Rienzi and some group in Japan, and we saw that the incidence of vacuole, deformity, crater, whatever you want to call it, is almost ubiquitous in all spermatozoa, even of donor sperm. And so we look at a different approach to try to look at the sperm while it's moving, try to use this voxel, so the computer reconstruction of the surface of the sperm. But we saw that as the sperm rotate, the morphology of the sperm change, so still this something ongoing, try to see how to understand what's the best looking sperm, and if actually there is a correlation. So we look at other characteristics, which is the genetics of the spermatozoa. So we're doing NGS on the donor sperm, here in the control. In the same patient, they come to our clinic, and actually we are able to provide them with the pregnancies. But the same patient that even after several cycles, we cannot achieve a pregnancy, they have a higher incidence of mutation, whether duplication or deletions. We also look at the epigenome. As you can see here, we try to query gene that assess the expression of the acrosome, the centrosome, like a PLK, the mitochondrial, the mid-piece, or the Casper, for example, for the motility of the flagellum. And these are all ongoing studies. We also look at the gene product within the compartment of the spermatozoa, whether inside the acrosome, the nucleus, the centrosome, mid-piece, and flagellum. So, and that's for the future. This is the PhD thesis that Queen Ineri got awarded post-mortem from Monash University under the supervision of Alan Transon, David De Kretzer, and Graham Jenkins. It was presented to the family last month by myself and Zev Rosenweis, together with an endowed fellowship of $1 million to Cornell University in her name. And this is reproducing spermatogenesis in vitro in the mouse. Then there is a younger collaborator trying to cellularize seminiferous tubule on the mouse and see when you provide early spermatogonial stem cell and pre-Sertoli cell, if actually they recolonize. And you can see here some recolonization on the profile of the tubules, and that's the final product here. This is another work ongoing. And that's one colleague, a reproductive endocrinology fellow. It was his thesis. He tried to help patients with spermatogenic arrest or germ cell aplasia. He used human iPS cell, like stimulating them, or coaxing them into differentiation with different methods, was able to get the positivity of bulle or ball gene expression which is typical of the spermatocyte. So that's very encouraging, and there's also ongoing and a hope for the future. We also resurrected the somatic cell hybridization with another colleague there, another researcher at Cornell, and we were able to obtain actually blastocysts from this experiment and obtaining stem cell from haplodized blastocysts. So, and that's how I envision for the future. I hope I can get this started. Can somebody help me? Supposed to start automatically? Yes. So this is the size of a cellular phone where you actually put, I mean, there is a complex machine behind this, but that cartridge will be very inexpensive. So you put the oocyte cumulus complexed on one side. We put on the other one the spermatozoa. Then automatically the machine will be able to remove the cumulus cell by progressing this electromechanical valve exposed with the kind of little amount of hyaluronidase, and by suction try to remove. Why did it stop?
Still moving.
No, it didn't stop. Okay. The cumulus cell, then progressing on the magnetic matrix track, face recognition. If the oocyte is not considered mature, it gets put on the side. If an M2, then we'll proceed or progress. Then bisection is held in place. On the other hand, the male gamete is selected, permeabilized by laser on the flagellum, then inject into the oocyte. This will be very helpful, at least for regular cases of ICSI, if ICSI is going to be the insemination of the future. And then it goes in an area very similar to the embryoscope we have today. So we can conclude that ICSI remains a popular insemination method, that we are constantly testing its boundary, trying to see what the applications are and how safe it is. ICSI can be used with any source and maturity of the sperm cell, as we see. We also have confirmed the safety of surgically retrieved spermatozoa, we believe. So we are always looking to new methods to identify and select the best male gamete, and we're doing that by querying the genome and the epigenome. And I close here by acknowledging all my collaborators. Thank you very much.